Good afternoon and welcome. And thank you for being here today at the Behavioral Health Echo Series. This is a training brought to you by the Center for Substance Use Training and Telementoring CSTAT, a division of the Be Well Institute at UT Health San Antonio. My name is Andrea, and I will be helping to facilitate this conversation today. So again, welcome to all of you. And before we start, I want to remind you of a couple of items. This session is being recorded, and you may find it later at our Be Well Texas YouTube page. That's in case you want to revisit this session. The information that you see on the chat will not appear on the recordings, so we invite you to continue entering your names, email addresses, affiliations, and credentials on the chat. We will need this information to confirm your attendance to this class. But if you're joining via phone, you may also send the information at cstat@utesca.edu, and that way we will match your phone numbers with your names. For captionings, as always, you may go to the bottom part of your Zoom windows and click on the captioning feature. And most importantly, please remember that these sessions are an open space of all teach and all learn. And what that means is that your input, your perspectives are incredibly valuable to this learning experience. So please feel free to unmute yourselves and give us your takes and your opinions, whether it's in the first part of the session, after our presentation today, or during the case discussion in the second part of the session as well. This is your space. These echoes are made for you, the learners. So we're going to start with introductions today, but we want to introduce a very special, someone who's very close to BUL Texas and CSTAT. Dr. Leslie Manson is officially joining us as our hub expert here at Behavioral Health. Leslie, would you like to introduce yourself, please? And welcome.
Thank you very much. It's good to be back doing echoes here with Be Well, so I really appreciate that. I just would love to take a quick moment. I'm Leslie Manson. I'm a licensed clinical psychologist, clinical associate professor, and I do international consultation for building fiscally sustainable behavioral health programs into medical settings for whole person care. So that's just a little bit about my background, and I really appreciate being here. Hopefully, I can contribute some of my over 20 years of experience being in clinical care as a psychologist. Prior to that, I was also a master's level mental health provider within the community medical health settings as well. So I'll be bringing that lens here to this collaborative. So thank you all. I really appreciate being here.
Well, welcome to the Behavioral Health Hub. It's a pleasure to have you with us. This will be your first session with us. So, Dr. Antoine, would you like to introduce yourself?
Hi, yes. My name is Dr. Dennis Antoine. I'm coming from Baltimore, Maryland today, where I'm the director of the Addiction Treatment Services Program and also the Center for Addiction and Pregnancy. Looking forward to having the conversation today and glad everyone could make it out.
Thank you, Dr. Antoine. And of course, Dee-Dee Stout, would you introduce yourself, please, to the group?
Thanks, Andrea. I'm Dee-Dee Stout coming from Emeryville, California, so the Bay Area. And I am an associate professor at St. Mary's College in Moraga, California, not too far away, and also run my own private practice, Dee-Dee Stout Consulting. I have been in private practice for about 35 years, and the same with teaching in various places around here. I've worked in the addictions field primarily, but my master's is in health counseling, so I do a broader spectrum. And that has been almost 40 years now. So no wonder I'm tired. Nice to have everybody here.
Thank you. Thank you. Thank you. We're very happy to have you here. Jasmine.
Hello, everyone. My name is Jasmine, and I'm the program coordinator for a couple of our ECHO programs, and I'm the program coordinator for our Behavioral Health ECHO. Thank you for joining us today, and I hope you enjoy our session.
Thank you, Jasmine. And I think that we can start sharing our PowerPoint presentation so Dee Dee can take it away. whenever you're ready.
Okay, I do that and say, so this is going to be a little bit different today in that Dr. Antoine will be doing the case presentation. So this is going to be a little bit more of a free form. But basically what we want to talk about are modalities and outcomes. And I put in a chat about what works and how to know. So what we're actually talking about here, you could think of as success. How do we measure success? How do we talk about and think about evidence-based practices and programs? Since the NREPP, which is the National Registry for Evidence-Based Practices and Programs, no longer exists and hasn't now since I think 2016. It was dismantled, which was really a shame. You know, one of the things that was in that area was motivational interviewing, which is part of my expertise. And I remember Bill Miller talking about how long it took him to get that certificate. He was quite proud of it because of all the work that it took. So that's what we're going to generally look at today, but I'm really interested in hearing from all of you and how you see these and the importance or maybe the non-importance of evidence-based. So moving forward, next slide, please. My disclosure, I don't have any financial relationship with anything I'm discussing here, but I do have personal relationships. So next slide. Learning objectives, we'd like to at least define the common factors in counseling. That's part of what I want to talk about today. 3 evidence-based modalities to treat substance use disorders, and then describe why outcome measures are important for good clinical care. Next slide. This is a phrase that I first heard in my first job in treatment, in hospital-based treatment back in 1988. And my boss, Rich Pelletier, you can see there, used to say to us, people don't care how much you know until they first know how much you care. And that has really been a touchstone for me, working through, going back to school, kind of learning and expanding my own base of knowledge and modalities, and realizing that I can know all of these wonderful modalities or interventions. And what really matters is the person that I'm sitting across from, whether that's on a little screen like I spend so much of my time now, or in an actual live setting. By the way, we think that came from Theodore Roosevelt. Nobody is really sure. Next slide, please. So how do we define evidence-based practices? Well, here you go. This is the official definition. Interventions that are basically seem to help at least a majority of people is what it comes down to. There are some other pieces that need to be part of that, and you can see those here. Guided by the best available research evidence, practice-based expertise, cultural competence. I don't use that phrase. I use cultural humility or sensitivity, and the values of the individuals receiving services. I'd like to underline that. One of the other things that we know about practices of any kind, or again, interventions, is that we, the clinician, need to believe in what we're doing, but more than that, so does the client. If the client does not believe in the modality or the intervention we're using, it's probably not going to be successful. It was our own motivational interviewing Bill Miller that did a lot of those studies, and I found those interesting. So we really need to understand the values of the person. Next slide, please. There we go. So here are a few evidence-based practices, and that's being defined by SAMHSA. This is not me, but you can see at the top of the list is motivational interviewing. Then you've got a bunch of cognitive behavioral therapies. We have a lot of offshoots of the basic CBT that I learned some 35 years ago as part of relapse prevention, because that was my area when I first started in the field. Contingency management, which is seeing a revival, which is quite exciting. Trauma-informed care. I think most people know something about trauma-informed care now. SBIRT, which I hope that we all know something about, particularly in substance use disorders. It stands for, as you can see, there's screening, brief intervention, referral to treatment. Forgive some of my abbreviations there. 12-step, there's a question. It's not evidence-based. You know, therapeutic communities, that's TCs, that's another one that is not evidence-based. And Q exposure is quite controversial. For some people, having Q exposure could be really helpful. So think PTSD. If we're working with veterans, you show them, and this has been shown to be quite helpful with VR, virtual reality, or some of the other AI sort of processes, that we can show them some of the battleground scenes and watch what happens to them physically, somatically, if you will, and help them to work through those feelings, help them to feel safe and understand that's not really happening anymore. That would be Q exposure. In our world, in the substance use disorder world, that would be showing somebody alcohol in front of them or cocaine in front of them, and what we might call refusal skills. How do we do that and lower their triggers, if you will? It's also about, oops, sorry, I've got a box there, culturally responsive care. And that's something that we've talked about here on the Echoes a lot. And I love that, how we need to be sensitive to people's culture. And culture is not just about your historical or your heritage and your background, right? It can be the gender, it can be age, it can be religion, it can be all sorts of different things. Culture meaning the greater sense of just how you were raised and how important that is, or not. For some people, it's not. Housing first is another one. Co-occurring disorder treatment. That we know is really important. A lot of folks who also meet the criteria for substance use disorder have a secondary co-occurring disorder, a mental illness that comes along with that. We want to make sure that there's person-centered planning. In the state of California, we require that the patient agree to treatment and sign that they do agree to this particular treatment. Or if they don't, then they have to be given other choices. Doesn't always happen, I know that, but that's the way it's supposed to work. Prevention is another part, and process improvement. How do we continue to improve our services? Next slide. So the behavioral therapies get called frames sometimes. That's the acronym. You'll see that used in the very first edition of Motivational Interviewing, the book that I was trained in, so back in 1991, if I remember right. And here's what FRAME stands for, and I think it's still relevant. Feedback, responsibility, advice, a menu of options, empathy, and self-efficacy. So in behavioral therapies, those are some of the things we're looking at. One of the areas that's really big right now is called feedback-informed treatment. It has some other names as well. I know it as PCOMS, FIT, feedback-informed therapy. And the other piece is called deliberate practice. And those things kind of come together in saying, if you want to become really good at a certain modality, then you need to practice it and you need to get feedback on that. So thinking, having a supervisor or a coach in whatever modality that you are trying to learn, it would be more like learning to play golf or the guitar, rather than sitting in a classroom and understanding it theoretically, but not necessarily knowing what does that look like in a session or in the work that I'm doing, which we find really important. Responsibility, both of the clinician and the client. Advice. Now, advice, yes, we give advice. We want to make sure we're using our good motivational interviewing advice giving skills and saying, ask for permission first. Don't just jump in. A menu of options comes directly from Bill Miller in motivational interviewing, but also in other health situations. We would like to have a menu of options for folks, right? Sort of the smorgasbord of treatments, and say, you pick something here. I can discuss with you the pros and cons of each of them, and we can have that conversation. And then you, my client or patient, really need to choose which road you want to go down. If it doesn't work, no harm, no foul, come on back and we can try one of the other ones. Just don't give up. We can keep trying here. Having a lot of empathy is so important. With the health challenges that I've had in the last couple of years, the one thing that has been the greatest about the medical team that I still have is their level of compassion and empathy. And that has made all the difference for me to be able to get through the last couple of years mostly intact. And self-efficacy, right? We really want to help people in harm reduction psychotherapy. We talk about self-determination. It's the same kind of idea. I call it with each one of my clients, I'm trying to work myself out of a client. I want them to be able to walk out of the session or out of the room and have some tools that can help them to make the next change that they want to make in their life and not be dependent on me. Not good for paying my mortgage, but great for them. Next slide. So here's a couple, and I used alcohol only just because it's easiest. I might also remind us in this day of opiate crisis that it still is alcohol that, other than nicotine, which kills nearly 500,000 people a year here in just the United States, alcohol is the biggest killer of people if we want to look at kind of overdose rates. We're at about 160,000 people in the United States alone die from alcohol-related conditions. I had a former client die a couple of weeks ago from exactly this at 40 years old. Okay, so it's serious. And the combined study was one of the biggest ever in this country. You can see that looked at 1,400 people with alcohol dependence who became recently abstinent, so they had stopped drinking. And they looked at 3 different interventions, if you will, or modalities. The psychopharmacology, I can't even say that this morning, pharmacotherapy, behavioral therapy, and then the combination of those 2. And they used naltrexone, as you can see. And isn't this interesting with the conclusion? Nothing was more effective than naltrexone or CBI with medical management. Placebo, so any placebo, a sugar pill, if you will, and meeting with a healthcare professional can have a greater effect than the CBI alone. And the CBI is the cognitive behavioral intervention. Isn't that interesting? Right? So what's most important here? Here we come with the empathy and compassion. All right, next slide, please. And the other one is the big one, Project Match, which many of you may have heard of. It was 7 years in the doing. This is part of where Bill Miller became quite famous in motivational interviewing. It was not motivational interviewing that was used because motivational interviewing was designed to work to be effective in 1 or 2 sessions in the beginning. All the others had 4 sessions, so he had to expand it, and he called it MET, motivational enhancement therapy. So that's where that phrase comes from, if anybody wonders. But that was one of the things looked at, along with cognitive behavioral coping skills and 12-step facilitation. So we didn't look at 12-step meetings, but just getting people to connect with 12-step. Okay. Patient treatment matching isn't necessary for alcohol use disorder since all 3 modalities are equal in effectiveness. Isn't that interesting? Now, that has not been found to be true in other countries, but I won't go into that today. Next slide. Some of the critics of Project Match, and some of these you can see, my buddy, Dr. Stanton Peele, is one of them who complains that there was no control group, and he's right. And any RCT that we do, the randomized clinical trials, which are the gold standard in this country, they all should have a control group. We did not have a control group there. So that's accurate. Therapists were more highly trained, and they were highly supervised by Bill Miller himself, who developed motivational interviewing. That's not typical for most of us working in this field, that we're not going to have that level of proficiency in something like motivational interviewing or even cognitive behavioral interventions. So you can see there are all of these different problems. Even George Vaillant, who is a well-known medical doctor, has written a couple of great books. Researchers need to examine differences between alcoholics. That's his term, not mine. Those who succeed in abstaining, who don't, versus the contrast among the professionals who run treatments. So again, looking at who's treating the people who are receiving the treatment. How do we manage to keep that consistent? Well, you can't. And a pioneer in the development of behavioral treatment for alcohol use disorder. My late mentor, Dr. G. Allen Marlatt, up in University of Washington, Seattle, says that the study was poorly designed. Everybody can now project their own views about alcoholism onto this study. So it's part of the problem. If nothing works well, or if we can't match people with the treatment, then what does that say about the treatment interventions we have? Next slide. This is all called the dodo effect. And Saul Rosenweg, back in 1936, if you can believe this, took a line from Alice in Wonderland, as you can see here. And the line was, everybody is one, so all must have prizes. And he said, this is the problem in psychology with our modalities or our interventions. They all work well for some people, right? And they all, you could call it the other way, they all work equally not well for some people. And that's a dilemma. So since all approaches achieve similar results, this is directly from him, the results in psychotherapy must be more than the presumed differences among the schools, right? So it means that there's something else going on than just what we're learning. Everyone can claim success. Well, that could be a good thing. It could be a not so good thing, and something in between. Next slide, please. So what are the common factors? And you're going to hear this phrase even more, I think, coming up in the future here. The common factors are the things that we look at. What are we doing in common that seem to help people? And the very first and the most important one is the therapeutic alliance. In fact, Barry Duncan and Scott Miller, who I have trained and am friendly with, both of those folks, talk about the therapeutic alliance. So our feeling towards our clients and the strength of that relationship can account for up to 60% of change. That's huge. The actual modality that we use only accounts for about 17% of the change. So back to my boss, people, don't care how much you know until they first know that you care. All right, that is really true. Empathy and unconditional positive regard are another part of this. Client expectations. Again, back to what do they think is going to be helpful? Do they think that this could be successful for them? If they don't, it probably won't work. Then we have the therapist effects, by individuals, the differences in each of us that we bring to this. Next slide, please. This is the fancy slide coming from Dr. Barry Duncan. I thank him very much for sharing some of his slides with me. His model is called P-combs, and I'm going to show you what that looks like. He and Scott Miller have devised the only evidence-based outcome measure that I could find. It's one that I've used for a very long time, about 25 years, and find it very effective, because the challenges about outcomes is most patients or clients find them very cumbersome, as do the clinicians. They wind up being 30 questions long, and who wants to spend part of their short period of time with someone doing that every single session? Whereas this one is 4 basic questions every time. Plus, people get to grade us every week too. We'll get to that. Next slide, please. So the heart of change. And this was first talked about, these outcome measures is what these are called, in the book, The Heroic Client, which is one of my favorite ones. I think it was written in 2000. It absolutely changed my life. And the outcome rating scale, or the ORS, is what you're looking at here. And what people do is put essentially a marker, a little line on this line, the horizontal line that you see, to determine, and it's actually between 0 and 10, but they take the numbers off so that doesn't bias people. And they just mark, in the last week or whenever I last saw you, how are you feeling individually? How are your relationships? How are you doing socially? And then kind of overall, how have things been? And then you take that and add them up and plot it on a graph, which I will show you. So one of the biggest pieces of this is this idea of partnering with the clients, of saying, I'm interested in this feedback and what's going on for you because I want you to get better. I'm not interested in you staying sick, quote unquote, or staying stuck in these behaviors. And I want to make this really simple for you to be able to both measure your own success, but for us to have this conversation. One of the things I like to do with my own clients is say, let's check in every about 8 weeks and say, how are things going? Is this the direction you want to go in? Because if it isn't, if this intervention that I'm using right now is not as helpful as you thought it might be, I've got plenty of others and we can try something else if you're interested. If you're not, then we used to call it the Rolodex. Now it's, electronic, lots of folks that I could suggest that you check out as well. So I can refer out as well. So there's lots of options, that menu of options again. Next slide. So here's the other side of that in paper, if we were looking at it via paper. This is available in electronic form, which you do have to pay for if you do it that way. The paper and pencil one is free. It's on both of their websites, both Barry Duncan and Scott Miller, and I've given you that information at the end. So the other side, the soul of change, is that alliance. And are we aligned? And you can see here, so we're looking at the relationship. Are we working on things that I want to work on? Is my therapist listening to me? So these are really important questions. And we know what the cutoff is for people that are successful. Let's see the next slide. I think it's in there. There we go. So here's the graph. And you can see for the ORS, for the outcome rating scale, the line of demarcation is at 25. And what that means is people who score at 25 or under are more like people who are looking to make a change in their life. People who score above 25 are people who have already made a change or for whom there is no change that they want to make. So things are going well. So that's kind of where we want to get to, help folks to get to that point. All of this is explained to people. There is nothing hidden from our clients. For the session rating scale to rate me, my line is much higher. It's at 35. So if I'm not hitting 35 or higher most of the time, I may not be a good fit for you. And that's okay. I call it the George Costanza breakup back from Seinfeld, right? It's me, it's not you. And that's the truth. If I can't give you what you seem to need, and that's okay, because there's lots of folks out there, let me connect you to somebody else who does something else. Or again, would you mind if I tried something else? Can we agree on another modality? And this can be the leaping off point for that. Next slide. So all of this to say, so what makes a great therapist? And you could add counselor, you could put coach, you could put any doctor, I don't care who it is in there. It doesn't have to be just a therapist. It's about getting feedback. I need to know if this is working. I don't need to know by my measure, right? I need to know by your measure. That's what's important here. When I was trained at the hospital back in the 80s and 90s, it was all about how we perceived the client doing or the patient in those days, right? That we gave the diagnosis, we gave the prognosis. It was up to us, not up to the client at all. That's changed. The heart makes a great deal of difference, right? This is the client's account for most of change. We need to understand that. This is their lives as well, not ours. So I really want to listen deeply to my clients or patients. I really want to know what they think and what they feel. The soul, we're back to the alliance. That is the number one thing. In motivational interviewing terms, we would talk about, connecting. We want to engage people all the time. You might remember from my slide from the MI talk, that's the step of the 4 tasks that's the longest because we're always engaging, hopefully. And the last piece is tracking our outcomes and learning. I've done these measures for long enough that I know that if I'm going to be successful with somebody long term, it's going to happen in the first 3 or 4 sessions. they're going to begin to see some change. They're not going to make the big change, but there's going to be some positive movement. If there isn't, I'm probably not the right person to work with them. In a practice, it's easier, you can share clients, right? Or you can say, hey, if you take my 1 o'clock, I'll take your 3 o'clock. I don't have that privilege anymore, that honor, but that's great when you do and you're working in a group. Next slide. So all of this to have our final tips here, modalities are absolutely important. I really want you to hear that. It provides us with some guidance. It certainly gives some guidance to clients and patients and their families about what they might look for in good treatment. The clinician and the client both need to believe that this modality is going to be effective in order for it to be possibly successful. But even EBPs shouldn't be seen as appropriate for all clients. That's really important. Just because it's evidence-based does not mean it's going to work for everyone. And so, don't get attached to your own, evidence-based practice. The outcomes are also important. How we measure success is important. And part of the trouble is that we seem to do apples and oranges. Every rehab, every clinic, every place has their own measure of success. And I think we need to work towards a singular, at least one that can be overarching. And then if you want to do your own underneath that, that would be fine. But it's really hard for us to know what's working when we have all these different measures. The most helpful is the point of view of the client, not the clinician. We really need to move away from that. I'm going to suggest the prognosis for this client or patient. It would be best, in my opinion, to include all of this in clinical training so that people get used to having these outcome measures. It doesn't become a burden. And bottom line, to invoke Bill Miller again, the way that we learn motivational interviewing the best is to pay attention to your client. Is it working for them? If not, as Scott Miller would say, stop it immediately and do anything else than what you're doing. Last slide, I think. And there's just my sources. Part of it was a personal conversation with Barry, which I really appreciate, and a couple of books and articles. I think there's one more slide for the sources today. There we go. Bruce Wampold, by the way, is sort of the guru of outcome measures. He's been talking about this for many decades. Threw in one for SBIRT, in case you're not familiar with that. Last slide is just a big thank you. That's it.
Thank you, Dee-Dee.
You betcha.
And a reminder to all of you that we will be sending the slides with all these resources in it right after this session. So for now, let's open the floor for questions to our speaker, to Dee-Dee. I have one question.
Go for it, Andrea.
Yeah, I've heard that sometimes when applying evidence-based practices, sometimes unintentionally, you might be reinforcing biases and misconceptions. How much of the truth is that?
Well, if you mean that we get attached to our modality, that kind of bias, absolutely. That happens a lot, in fact. And understandably, I mean, it becomes this double-edged sword, right? I have to believe in what I'm doing, or it may not be effective. And yet, if I think that that's the only thing that can be effective, now I'm in trouble. So that's the balance. It's like, we can use a great example is some folks believe very strongly in AA or 12-step, any kind of 12-step. That's great. However, it's not right for everyone. And so I wind up having long conversations sometimes with clients about the pros and cons. And, would this be helpful for them, or what part of it might be helpful for them? And ultimately, the biggest thing I wind up working on with clients about any modality is giving them sort of permission, if you will, to say, this isn't working for me, or I don't like this for whatever reason. It doesn't fit with my values. Because our clients like to be, I think, compliant, back to our favorite word, Dennis, right? They really want to be compliant, and we've kind of trained them to do that, to say yes, to give us what we want to hear. But then they walk out and they do whatever they're going to do, and then we don't get any feedback, or we don't see them again. And I know for me, sometimes it's because I've gotten too attached to my modality or my way of thinking about something. Gratefully, I've had some clients who did tell me that over the years.
Others from our hubs?
I was just going to make a quick note. I loved everything that you said, Dee-Dee. I've been using proms for forever and a day, ORS, S, but
Yep.
I'd love to hear, because I know not everybody uses them. And I'd love to see the folks that are on, if there's specific proms measures that you use now, maybe put them into the chat box to kind of share those resources. I've also used different qualities as well. So use the ones from World Health Organization, dailies, Dukes, as well as other prompts out there as well, dependent on the patient's symptomatology or diagnosis or needs. You can use those in addition, to if you're using standardized like an OS or SRS as well. But I'd love to just see if folks are using any specific outcome measures, perhaps put them in the chat to share so that everyone can have resources and different ideas of what to consider and implement in their practice. I think that would be great.
Yeah, one of the things that I don't think you were on yet, so thanks for that, Leslie, that I mentioned was because I didn't want this to come across as a big advertisement for ORS and SRS. That wasn't my point. I couldn't find any other outcome measurements that were evidence-based. And I found that fascinating, and not for therapy, at least. For other areas of behavioral health, there very well may be, but not for counseling and therapy. There are a lot of different measurements you can use for specific conditions, but not overall for, is this working? This conversation we're having. They're all important. Absolutely. They're all important. And thanks for bringing that up. Yeah. So the question was, can you link any modality with change talk for objective standards that are often sought by supervisor? There is something new out about change talk. I'm not going to be able to pull it up immediately today. Maybe that's something that we could return to. That's in the motivational interviewing realm, but we can talk more specifically about change talk. There was just a new study that came out on our group MINT, Motivational Interviewing Network of trainers that I belong to. And I found it really interesting. So there are some things that we can look at, both for what increases or encourages change talk, and what now we talk about softening sustained talk, or softening the, no, I don't want to make this change, that kind of language. So we can do both, and doing both effectively seems to help the best, rather than just trying to increase change talk, if that's of any help. Thanks for the question. I think it was Neville.
Yes.
Right? Sorry about that. Yes. Okay. And a couple of others. Okay. Great.
Yeah, I agree with you, Dee-Dee. It's in terms of counseling therapy, it's hard to find them. And because the SRS is one I tried to use a while back, and I was looking for a group version of it. And I
There is
couldn't.
one.
Yeah, if it's free now, let me know, because I actually want to use it.
I'll get that to you.
Okay, that would be helpful. But the ones I put in the chat are ones I use for specific conditions, overall physical health, mental health. But it's for therapy, that is a critical one to consider.
There's even one for kids that just has faces.
Huh, I like that.
Yeah, it's great. I kind of forgotten about those because I don't use them anymore. Thank you. There you go. The SRSG. That makes sense.
Appreciate that.
So if we
On
don't
to the
have,
case?
Yes, if we don't have more questions for now, that is fine. We're going to move to the second part of the session after the announcements. And then, well, as always, we're going to try to link what we're going to be discussing in the case with all these practices discussed by Dee-Dee during the presentation. So if we can go to announcements very quickly, thank you. And to claim your CEU credits, please remember to answer the post-session survey link and answer yes on the question, are you applying for CEU credits for today's session? Please give it approximately 2 weeks for your certificates to be created and sent to you. It's very easy, but if you have any questions, you may always send an email here at cstat.utesca.edu. Next. And the Center for Substance Use Training and Telementoring CSTAT provides substance use disorder assistance for a wide range of needs. This is a free service that could be of great help for you or your organizations. It's very easy to just go to our page, complete that form, and someone will get back to you in 2 or 3 days. So please go to the page cstat.utesca.edu/contact us, complete the form, and we'll be happy to help. Next. And today we're introducing Andy. She is one of the team members here at the naloxone team at Be Well, Texas, and she has some important announcements for us today. Andy, welcome whenever you're ready.
Hi, everyone. Thank you so much for having me on. So as Andrea said, we do have some very exciting announcements. So first, we wanted to let you guys know a little bit about the program. So as previously stated, we do cater to both individuals and organizations. Individuals can order one box of naloxone, which contains 2 doses, and organizations can order up to 12 to 48 units online. We also have training and naloxone available at our 10 regional distribution hubs that are located all throughout the state of Texas. And also wanted to share some highlights, since we know that in today's political climate that sometimes things can be kind of shaky as far as the knowledge and what's going on, specifically for our program. So we wanted to let you guys know our success, which is that we distributed cumulatively of around 250,000 units of naloxone via our projects and the different funding sources that we have. And then, of course, 5,000 units of intramuscular naloxone, which is super exciting for our program. And we're really excited to continue to share. And we will be able to continue to share at least for the next 5 years with the TTOR open state funding program. So that's really great. And then also we also wanted to get you guys on a new opportunity, engage interest on having a naloxone vending machine available. So I will drop the link in the chat. But if you're interested in having a naloxone vending machine in your community, or you know community partners who may be interested, then please fill out this link that I'll be dropping in a little bit. Just because we really want to gauge interest. We know that our 10 hubs don't quite reach everywhere. And we want to make sure that all the communities that are in need and all the communities that need to be serviced do get this help that they need. And so, again, I'm going to drop this link right now. Please fill it out if you're interested. Thank you guys so much for your time today.
Thank you, Andy. Yeah, so that's the link in case you're interested in having a naloxone vending machine in your organization. Please complete that link or just send us an email here at CSTAT. And next slide, before we move to the case form, please join us next month. That's Friday, June 27th, for another session of Behavioral Health Echo. And now I'd like to move to the case presentation. This time we're doing things a little different, so I would like to reintroduce Dr. Dennis Antoine to the group. He's going to be sharing his experiences with one of his many cases that he sees related to substances. Then we'll open it to the group for you to give us your ideas and perspectives. Dr. Antoine, would you first introduce yourself and then you can take it away. Thank you.
Problem. Thanks again. I'm Dr. Dennis Antoine. I'm a psychiatrist by training, and I work at Johns Hopkins in Baltimore, where I'm director of two main programs. One is the Addiction Treatment Services program, which has a track called the Center for Addiction and Pregnancy. And as the name talks about, it treats individuals who have substance use disorders and co-occurring behavioral health issues. Another program that I'm part of is the Cornerstone Clinic at Helping Up Mission, which treats individuals who are unstably or unhoused, and also provides behavioral health treatment for them. Between there, we're talking about 300 patients and clients, and I use those names interchangeably at times, depending on the setting, between those two settings. And myself, I probably have a cadre about 50 to 75 individuals that I see on weekly or biweekly sessions. The case I'm presenting today is someone I've only met with once. So it's an interesting opportunity, but one that comes with a lot of, I think, thoughts and ideas that I'd want to bring up and get feedback on. Briefly, just to give an overview, this is a 25-year-old African-American woman who's identifies as heterosexual. And going through the themes of what we had before, the thoughts I'd want to make sure we bring to the forefront of the discussion are what modalities should we use? Where do you begin in counseling with her? And where do you think the things about her medical treatment should come into play, namely her HIV treatment and her cognitive impairment? And so thinking that through, I would say the challenges that I'm seeing with her are that she had been very stable for a while. She'd gone through a pregnancy that resulted in a child back in November of 2024. And she came to us after a few months of using fentanyl and also cocaine postpartum with increasing PTSD symptoms, had gone to a residential program, but finished that program due to the time elapsed, and is now with us at the Center for Addiction and Pregnancy. We still treat individuals postpartum up to 1 year. And she's now trying to continue her buprenorphine, but coming to me, there are a couple of things that have happened. One, her HIV treatment stopped right after her pregnancy ended, and so she's been off her medication for 6 months, having difficulty engaging with her program for substance and for her infectious disease doctor. I actually tried to make an appointment with her, and she says she doesn't want to go. And she also has a mini mental score of 20 out of 30. And typically I see people who are about 25 to 30 in that range, but hers, I would say, is fairly impaired. And she herself says that she's having difficulty even doing math, which has been a strength of hers in the past. So straightforward things like 100 minus 7, she cannot even do at this time. The goals that she wants are to just take her medications at nighttime. She doesn't right now want to engage in the different counseling sessions and is hesitant to go to the HIV doctor to get her medications restarted. And the strengths, though, I would see is that she is trying to seek treatment on some level, and she's motivated to keep her child because she is court ordered to this process to stay engaged with the Center for Addiction and Pregnancy and the housing program where she is for up to a year. Vaping is a big part of her picture. She vapes, as she told me today, all through the day and night up until about 1 a.m. And she is taking buprenorphine at this time twice daily. But as of about 12 o'clock today, she said that she was going to stop everything because she couldn't take it at the specific time that she wanted to, even though we wanted to talk more about the HIV medications and other things. Just given the whole picture here, she is in counseling beyond me. She has a separate therapist who talks about counseling goals and has done that in the past. No inpatient outside of the one program she was in right after her birth of the baby, and she has not done any mutual aid groups at this time, and never been on any other medications for opioid use disorder. But she is on Seroquel now for bipolar disorder, and we're trying to find a way forward on how to make sure that is the right dose for her or the right medication for her. There is also a history of childhood abuse that we haven't delved into deeply, but she mentioned that, and I try my best to use motivational interviewing, in addition to some peer recovery support services that are available at the housing program as well. So just giving a big snapshot, and what I did with her on the first session alongside the mini mental, which was a big focus for a while, was to see what type of symptoms she has. I used what I call the promise scale that I put in the chat just to see how she's feeling. And on the mental health side, she's feeling a lot worse than she said she had in the past. Physically, she says she's doing okay, but it's also interesting that her cognitive clouding was pretty clear to me. So putting it out there is a big snapshot. Again, I've only met with her once, but I want to get a sense, given that she has taken a few hours of my day today, and I'd be curious to get folks' input as to what would be helpful.
Thank you, Dr. Antoine. So we posted on the chat some questions, and we want to hear from our community of learners. If they have any ideas, like what modalities would you be using in this case? How do you explore her hesitation to restart her HIV treatment? How would you adjust your modality in light of her cognitive impairment? So,
And I see Leslie's question. Her CD4 count back in December, right when she gave birth, was in the 600s, and she was undetectable. So we do not have a more recent one. And that is the reason I would want to get her in to the doctor to be seen. She has an appointment set up for Monday, but she's already saying, I don't want to go to get that done. And so I think you're asking a great point. What's the most up-to-date status there? I think I should be getting the answer to those in the next hour, in terms of the reasons for hesitation. But I agree with you. That is something I would like to know. Her peer recovery specialists that are involved are going to be talking with her about that, and that's something I want them to look into for sure.
Melissa, would you like to unmute, please, and ask your question? Thank you.
Hey, I'm just curious. So while she was pregnant, was she compliant with her treatment?
So at that time, she wasn't on the buprenorphine, but she was compliant with and
HIV.
using her medications.
Uh-huh.
As brought up by Leslie, her CD4 count was beautiful. Her
Uh-huh.
viral load was beautiful. And she knows that. And I pointed out to her, you have a great track record to get back to. Let's figure out how we can get you back there.
And her motivation was
Back then, she definitely wanted to make sure that everything was doing well for the baby.
right.
And I think that is something we need to explore a little bit more.
Yeah, and so I guess my question would be, should we find a new target to shoot for that is equally motivating, I guess would be my question. And the second question I have is what was there any resistance, although she was pregnant, to the HIV treatment? Because now we have complete avoidance and we have to look at long term. She has this child in her life. Does she have any other children?
No, first child.
Okay. So, I mean, long term, you want to be around for your child. You see what I'm saying? That line of thinking. But because she has a trauma history, I'd be curious also, is there any resistance or triggers, reminders that might also be a little bit of a hindrance?
I can understand that. Yeah, and I think that's a great point.
Neville, would you like to mute yourself, please?
Let's see. Can you hear me?
Yes,
All
we
right.
can.
Yeah. I don't know. I was thinking like sometimes people might be fearful of people in the community finding out they're living with HIV. So maybe, is it a specific clinic in the area or, something like that that might be stopping her from seeking services?
It is something we should explore. This is a clinic that she'd gone to in the past, and she'd had great outcomes. And it's one of the well-resourced clinics in the city, and that she was trying to get to. So I was a bit turned around when she turned around and said, "Well, I don't necessarily want to go right away to this clinic." But I think stigma is something we should explore, given that she's relatively young, in the course of who I've been seeing. I mean, that's something we have not characterized yet.
Yeah, I mean, some of the people that I've worked with living with HIV, they're not really necessarily ready to give up the lifestyle. And so, of course, people find out they're not going to want to, have sex with them, let's say. So um, that might be a concern. And actually, I guess with HIV, it'd be better that she would be on her medications because she'd be less likely to, give it to someone else if she's undetectable.
I agree with that. Yeah, yeah. Yeah. So that is something we should look into.
Enrique, did you want to say something?
Actually, I did. So, for probably 9 years, what my role was a navigator within the linkage community for HIV services. And so I could understand a little bit of the hesitation given some of the medications are really caustic when it comes to pregnancy and that type of a thing. And one of the underlying fears that the majority of the consumers that I ever dealt with, given even the fact that now within the first 2 months, you become undetectable with the most of the medications that you have. It's one pill once a day. The misnomer remains the same that it's a death sentence. And the concern that every, well, maybe every is a little strong of a word. 90% of the individuals that I dealt with, the one and only concern they had was getting the pill. When can I get the pill? How long will it be? How much weight am I going to lose? I had an individual that was a rather healthy young man like myself, and he told me, well, what am I going to tell my parents when I lose 100 pounds? So why exactly would you be doing that? He says, well, everybody knows what an AIDS patient looks like. And as Mr. Mason was saying, I had an individual healthy, doing well and everything, but because the clinic had the term HIV in it, he refused to go to the services for that simple fact. And then some of the other things that are perks is now you can get a medication administered through injection, which is every other month. Here again, I don't know what the dynamics are. I've been out of that particular realm for about 4 years now. But this was significantly different than what it was before. This is, of course, administered through a medication type of a process. But the approach I always used to take with people is this individual that didn't want to go because it was an HIV clinic, I used to tell him the thing to understand is that there are places where you can go. You don't necessarily have to have your medication at your home because he had children and he had a wife and he didn't want them to find out. And I told him, well, it's really kind of unfair. Not my place to make you tell them or disclose to them. But you have a job, you have specific areas where you can hide your medication and take it once a day so that that way it's in the trunk of your car or it's in the place where you put your spare tire. Really, who's going to look for that kind of stuff? The important thing is that you take the medication daily, and the reason that it's important is not necessarily because yes, your health has an impact to it. And it's better for you to not take it for extended periods of time than to go on vacation holidays, because then that builds resistance. You don't build resistance to the one drug, you build resistance to a class of drugs. And when you build resistance to a class of drugs, there's only so many classes of drugs. When you get to the end of those classes of drugs, the only, well, here again, back 3 years ago when I did this, the only classification of drugs that was the end of the line was an injection twice a day. And so, putting it a little bit more into context, are you prepared to inject yourself 2 times a day, every day for the rest of your life when you can take alternatives? Go to work, put it in your drawer, lock it, and you take out one every day. On the weekends, you take it. Here's a little pill minder. Here's a little plastic baggie. Stick it where the spare tire is. Who is that exactly is going to be changing the spare tire if it's not you? So it was always different alternatives to kind of um, address the concerns, but the really underarching one was always, I'm gonna die.
And I think there's a couple of hands up and also in the chat there, and I appreciate those comments, Enrique. I think the approach I will use tailoring that content is where she is now. She is unhoused in the space where she has to be for the next 300 days almost court ordered. And so I'm trying to figure out that decisional balance, if you will, as to what is the thing here, because it literally can all be sent to her. She doesn't have to go anywhere. They will drive her wherever it is, and there are other options too. But I'm curious as to what's going through her head right now, whether there is that stigma, whether there is that name of the clinic, and it has a different name. But those are great things that you brought up. I see a couple of hands up still. If we have time, Leslie and Dee-Dee or others, but I'll let Andrea.
Yes, we're almost at the end of the hour, so I was going to allow Dee-Dee to ask her questions, make her comments, and also if she could briefly give us a summary of some of the things that we discussed related to the case today.
Sure. I mean, one of the things that I think I was going to bring it back to outcomes and sort of measures of success, Dennis, was what's important to her now. So as a mom, I can imagine that now that I'm a mom, the stigma behind being an HIV positive mother is very different, because now the stigma isn't just on me, it's on my child there potentially. And if that's playing a role and somehow in it. And so, again, I agree, Heather, that maybe her goals have changed. And so that might be part of the conversation. How do we talk about this? How do we measure it, if at all possible, in some way of it doesn't matter what your goals are, they can change. Absolutely. This happens all the time with all of us, right? Things change in our lives. So the goals change. And sometimes the language we use today is what matters to you. Instead of saying goal or outcome, that seems to be a little bit more clinical or technical. I've worked with a young man who has told me that his goal right now is around losing weight. We're working on alcohol. So he likes it going through a different door. So if I lose weight, I know I'm going to be drinking less because alcohol has a lot of calories. But if I look at drinking, that just makes me more anxious. So let me look at the weight, because that I can measure more easily. Okay, back door it is, or side door, or whatever it is. And I think that's what we're talking about today, is looking at how do we use modalities in a proper way, being whatever the client wants and whatever the clinician is comfortable with. It has to be a partnership there. And then looking at how do we measure whether this is working or not. And sometimes it can be just that simple, asking, how is this going for you? What am I missing right now? What are you not telling me? I really want to hear what you're not telling me.
Thank you, Dee-Dee. And we
Yeah.
appreciate those questions that we see on the chat. And we are going to have to finish here, but thank you all of you again for a great session. Please remember to answer your post-session survey, and we'll see you all next month. So thank you, everyone, and have a
Thanks.
great weekend.